welcome each and every one of you for this fantastic program. Every third Tuesday, IFS Tamil Nadu hosts a webinar. And this Tuesday, we are blessed that we have a great chairperson, Dr. Bridhamashni Madam from Coimbatore, to give her expert opinion as the topics go by. And we have our coordinator, Dr. Priya Kannan, who's also the Joint Secretary of IFS Tamil Nadu. She has picked a lovely set of topics and a lovely set of speakers as well. So we have three topics: poor ovarian response, stimulation protocols by Dr. Charmila Ayavu from Trichy. We have comments on oocyte quality when it comes to a hyper-responder. And for that, we have Dr. Varsha Samson Roy from Bangalore. And for semen parameters, to get an update with respect to the latest WHO 2021, we have Dr. Pranoy Ghosh, and he's from Delhi. So we have kind of the whole country bundled into today's webinar. And I hope and I promise that it will be a useful session because it has to percolate knowledge. And I request Dr. Priya Kannan to take proceedings further.
Thank you, Dr. Rajapriya. It has been an absolute delight to organize this. And because
right? Dr. Priya Kannan doesn't need much of an introduction. She will say yes, and she will try to do justice to every post possible. But it is still, I want to use this opportunity to introduce her. I've seen her right from a very young age as a budding and as today a very prominent embryologist, living up to her mother's name. She's currently the director of Garbha Rakshambigai Fertility Center. She was the past president of ACE India, and proudly she's my joint secretary. And I should say she has done her best each day, each moment to contribute to the academics in the field of reproductive medicine. So go ahead, Priya.
Thank you. Thank you so much for that kind intro. And it has been an absolute pleasure organizing this meet today, and especially to have Madam chair the sessions. Madam, as we all know, we all have learned from her right from the beginning, from the moment we started doing reproductive medicine. When I just had to have Madam on our panel, because when I was going through and adding our members, Madam, I found that Madam was the first member of IFS from Tamil Nadu. So I thought, let me have this honor of having Madam. So just a very small introduction of Madam. I don't think Madam needs any introduction at all. As I said, she's our teacher all around. We've always been looking forward to her topics and lectures and everything. Madam is, she had training from University of Manitoba, Canada, and fellow of Royal College of Surgeons, Canada. She is trained in all aspects of gynecology and obstetrics and in reproductive medicine. She's been trained in colposcopy, gynec endoscopy in Germany, infertility management under the late Professor Ratnam in Singapore, from whom we also have Professor Ratnam and Bongzo, or is a duo we all have learned from as well. And Madam is certified specialist in MRGFUS, treatment for adenomyosis and fibroids, one of the only two gynecologists certified in Southeast Asia. And prior to her association with motherhood, Madam was the head of Department of OB-GYN at Sri Ramakrishna Hospital and clinical director at Women's Center and clinical director at Assisted Reproductive Technology Center, also unit of Women's Center. Madam, I now invite you to introduce the speakers and start with the session. And thank you for being here.
It's a delight to be with all of you young ones. And I think I'm very, very happy to be here this afternoon and looking at all those bright, smiley faces around me. It makes me feel that we are still alive and IFS is still alive in Tamil Nadu. And a great job both of you are doing. I am watching somewhere from the background, and even though I'm not participating fully in it. And you've got three very good speakers today. And I think Charmila is very prominent in the national scenario. Varsha, if you want to pick one of the best in embryology in all of India, Varsha would be one of them. And the third speaker is probably new to the Tamil Nadu audience, but I'm sure with your choice, I think he'll be fantastic as well. The details of it, if you have a slide, I'll introduce them as we go on. But the topics are well chosen as well.
You can introduce the first speaker. They will project the CV.
Okay, I think the topics are very well chosen. And I think it's again a high responder and a poor responder, and something as basic as what do we do with the semen analysis has anything changed at all, kind of thing. So I think I'm waiting eagerly for all the speakers to come on board, and I'm with you.
Saiti, can you please put out the CV of the first speaker?
Dr. Charmila's.
Dr. Sharmila's.
Dr. Charmila Ayavu is somebody that I've seen for quite a while from Trichy, and somebody who's becoming more prominent by the day in the national scenario. At the moment, she's the Vice President-elect of FOGSI for 2024, Chairperson Clinical Research Committee of FOGSI as well, ICOG Governing Council member, National Coordinator for UNICEF, National Coordinator for MEDA FOGSI PG programs, National Coordinator for ISAR Gurukul, and WHO MDSR India member, past Secretary of Trichy OG Society, President of Menstrual Hygiene Management Consortium, Joint Secretary Gestosis Association of India. It's a wide spectrum of things, and I'm very, very happy to welcome you to be part of this today. And the topic as well is something that we talk about all the time, but nobody has all the answers yet, and I'm really waiting to see what your take on it is. Charmila, for you.
Thank you so much, ma'am. We have grown up listening to you, and we have learned from you so much. It's an honor to have you as a chairperson for this session. Thank you so much. I'd like to thank all the Priyas for the opportunity. Priya Kannan, Priya Selvaraj, and of course, Dr. Rajapriya Ayyappan, the Secretary of the IFS chapter. Thank you so much. I'll just share my screen. So it's basically the protocols which have come up for poor ovarian response. In the past 2-3 years, it's actually totally changed. Every decade is changing, but there's been a very rapid change in the past 3 years. Suppose you go into the Gardner's textbook of assisted reproduction, the two editions are totally different for the management of poor ovarian responder. What was done in the previous textbook has totally changed in this textbook. So I'd just like to go through the changes which have happened. So what is actually a poor ovarian response? A typical response is where you have 10 to 15 oocytes coming after a conventional ovarian stimulation. And there is a significant proportion of patients when you do an ovarian stimulation who have a poor response when there are less than 4 oocytes, and it's called a suboptimal response. We have only 4 to 9 oocytes retrieved. So anything below 9 is a poor response, and it's suboptimal when it's between 4 to 9, and it's really poor when it's less than 4 oocytes after conventional stimulation. And that is, it's a good response if you have 10 to 15 oocytes. So it's actually the failure to respond adequately to a standard protocol. And also when the patient is unable to recruit adequate follicles even when they are there, that is an unexpected responder. And both the conditions are called as a poor ovarian response. And this is extremely important because this forms the critical cornerstone of any assisted reproductive technique, because it's an independent predictor of the likelihood of pregnancy. So more oocytes you get, you'll have a much better result. But with a new AR table coming and asking us to do with only 7 oocytes, I think they want everybody to have a suboptimal response to get a result. So the prevalence of this condition fluctuates between 5.6 and 35.1%. That's quite a wide range because nobody has got a good definition of what is actually a poor response. And why it is important is, as I said before, the results are going to be poor when you have lesser oocytes. The number of resulting embryos is reduced, which will jeopardize the treatment success. The cost will become much higher in these responders compared to a normal responder, because you need to go for different strategies or repeat treatment cycles, which makes it very expensive. And these factors are going to cause an emotional, physical, and financial distress for the couple, particularly when you're going for multiple treatment cycles to get the required number of oocytes. And the etiology, it's quite heterogeneous and it's very difficult to characterize. But there's one central element to this condition, that is the presence of a reduced number of follicles which are responsive to follicle stimulating hormone. And that's the central element there. And it's quite often happens at advanced maternal ages because of the reduced reserve caused by an accelerated follicular loss because of age. So the factors which affect the response, as I said, is age is the first factor. The cause of infertility will contribute, the body weight of the patient, the body mass index, and the ovarian test results are also going to contribute to the response. The ovarian characteristics by your ultrasound, the number and size of antral follicles, the ovarian volume, and the ovarian vascular resistance by Doppler are all going to affect the response of the patient when you're going for a conventional stimulation protocol. So there was so much of confusion regarding the definition. There was actually one definition, just the Bologna criteria, and that was not accepted in many centers, but that is the only one which is available now. In that, you need at least 2 of the following features to say that the patient has got a diminished ovarian response or a poor ovarian response. And that is if the lady is of advanced maternal age, or she's got a risk factor for a poor ovarian response like endometriosis or any surgeries on the ovary, or suppose she's having a previous poor ovarian response in a previous stimulation cycle, or she's got already an abnormal ovarian reserve test in the form of AFC or AMH. But always remember that you need at least 1 stimulated cycle to say that POR is definitely there. So that was the criteria for the diagnosis, the classification of the disease. And there's something called the Poseidon criteria, and that is a spelling I put up because when I was talking to Priya, I was pronouncing it quite wrongly. So it's actually Poseidon criteria, and that's for the treatment strategies which are being formulated. And it's actually a patient-oriented strategy encompassing individualized oocyte number. So the Poseidon group was formed for that. It takes into consideration both poor ovarian reserve and a poor ovarian response. Both are there in this formulation of this criteria. And this is the Poseidon criteria where group 1 and group 3 are the young people, and group 2 and group 4 are the older people. That is, group 1, when the lady is less than 35, has got a normal reserve test, but she's having a poor response in a previous cycle. Group 3 is a lady who's actually a younger age, but still has got a poor reserve in the form of a AFC less than 5 or AMH less than 1.2. Group 2 and group 4 are the older people, that is above 35 with a good reserve testing. And the group 4 is the one who is having an older age as well as a poor reserve testing. And the number of oocytes retrieved in the previous cycle also comes into the grouping. And in group 1, it is a suboptimal response and a poor response, and that is less than 4 and 4 to 9. And what will be the outcome when you're going to manage these patients is the group 2 and 4 will have a higher aneuploidy risk, whereas the younger people, even though they have got a poor response or a poor reserve, they will have a lower risk of aneuploidies. But all the groups will have a few embryos generated, and that will reduce the cumulative live birth rate. So this is how it is actually the reasons for these unexpected poor response and for the expected poor response. And that is a person who's got a good reserve testing when you're doing all the tests for ovarian reserve, and she will be a young person with probably a decreased number of the FSH receptors, and that's why she's not responding adequately to a conventional stimulation. There may be a defective signal transduction. There may be an inappropriate local vascular network. There may be autoantibodies are going against the granulosa cells. There may be an excess of vascular growth factor receptors. There may be an abnormality in the insulin growth factor 1 and 2 levels. There may be a diminished circulating gonadotropin surge attenuating factor, the bioactivity of which may be diminished, and there may be FSH gene polymorphisms. It all happens in group 1 and 3 actually. That is, a person who has got any of these changes, problems, and we are not able to identify, and she goes for a stimulation protocol and does not respond much. The other category of unexpected poor response, where you have not used the optimal level of gonadotropins to stimulate them and you've got a poor response, and that happens in group 1 and 2 have got a good reserve testing in them. And regarding the expected poor response, it is actually the young person who is having a low ovarian reserve because of advanced endometriosis, a prior ovarian surgery, or pelvic adhesions, or is obese and she's got a smoking habit. This person is going to be a poor responder, and it's quite expected, and you have to manage it accordingly. Group 4 is the one where you have an advanced age and an abnormal ovarian reserve testing. So there's a genetic background for these poor responders. Several polymorphism of the FSH receptor gene have been discovered, but the ones which have been studied in many studies is actually the SER680 ASN and the THR307 ELA. And they have found out that these people, the people who have who got these polymorphisms, will have an ovarian response to the FSH stimulation to be much lesser compared to any other person. And suppose they have got a change in the genotype of SER by SER, it will be like more resistant to FSH action. This is extremely important, even though it's in the research phase. If it comes to the clinical application, it's going to help us to apply these genetic markers as a routine diagnostic test before you do an ovarian stimulation, so that you can predict the response, determine the required dose of FSH, and avoid the possible complications related to the FSH stimulation. So in group 1 and 2, that is the ones who have got adequate reserve, why do they respond very less? That is an unexpected hyper response. They call the so-called normal reserve test, but still do not adequately respond to the stimulation protocols you form. So how do you manage such a condition who's got a hypo response? Can you double the dose of the gonadotropins which you started earlier, like go up to 450 and 600 and all that? It's not going to help at all, because it will any dose beyond 300 IU is not helpful at all according to many studies, and even there was a position statement on that. And this is not going to be effective when you increase the dose of gonadotropins, because the follicular recruitment is going to occur in the late luteal phase and the early follicular phase, and then increasing gonadotropins beyond the early follicular phase is not going to help at all. And any dose beyond 300 does not seem to help. And why that happens is because there's something called a saturation kinetics which will develop, and it will block the usage of these gonadotropins. And actually the response depends on the number of follicles available for recruitment rather than the dose of gonadotropins you're going to help. There's another study in 2015 where they have said any dose beyond 300 is unlikely to be useful for a hypo response. And the other treatment which you can give for a hypo response is the addition of recombinant LH. And it's very helpful for hypo responders rather than those with a classic poor ovarian response bars reserve. Anybody who's got a low reserve may not be benefited with addition of recombinant LH, but if she's a hypo responder belonging to the category 1 and 2, probably she will respond. And this was actually proved by a systematic review in 2018, which was called as the International Collaborative Group for the Study of Rec LH, ICOS LH. And when there's a clear distinction between a hypo responder and a classic poor ovarian reserve patient, when you add LH to the person who's a hypo responder, it's going to have much better benefit compared to adding it to a person who's got a poor ovarian reserve. So the other study which was brought out in 2014, they've said it was noted that significantly more oocytes were retrieved in a REC LH supplemented cycle than in a recombinant human FSH monotherapy cycle, and the clinical pregnancy rate also increased by almost 30%. So we know that the cheaper option for LH is HMG, having both together. So does the source of LH preparation actually matter? You can be actually quite happy that you can use HMG, because there's no statistically significant difference when you give REC LH with REC FSH compared to giving just HMG, which will give you equal results, and that was brought out in a study in 2019. So regarding the other groups of group 3 and 4, where it's going to be an expected poor response because they've got an ovarian reserve which is low already, you need to go for an individualized regime, and you may need to go for pharmacological intervention which should be combined with oocyte and embryo accumulation. So these are the different stimulation protocols which have been advocated. And conventional IVF, all of us are quite familiar with, where you give exogenous gonadotropins and you induce multiple oocyte development for retrieval. Natural cycle IVF, where you don't give any drug except you take out the egg which is getting formed. Mild ovarian stimulation is where you use only 150 IU of gonadotropins, and you can add oral agents like clomiphene and aromatase inhibitors like letrozole to this cycle. You can use only low dose exogenous gonadotropins. You can add antagonists, and you can add actually a late follicular phase HCG or luteinizing hormone, which can actually help in getting the required number of oocytes. Or you can go for a modified natural cycle IVF, where you have antagonists in the late follicular phase. And sometimes, if you want, you can even add a little bit of gonadotropins, and ovulation trigger is with HCG. These are the different protocols which have been advocated for group 3 and group 4. And regarding group 3 and group 4, the practice committee guideline of the ASRM in 2018 was for mild ovarian stimulation protocol, where you use only 150 international units of gonadotropins. You can add oral agents, you can add GnRH antagonists, and you can add late follicular phase HCG or luteinizing hormone to increase the number of oocytes. And there was actually no definition for mild ovarian stimulation before the ASRM practice committee proposed that when they are doing a study with a daily dose of 150 international units of gonadotropin with or without oral components, it should be considered as mild ovarian stimulation. And they have said you can consider for treatment in poor responders. Mild ovarian stimulation seems to work much better than the conventional stimulation. And what about when you add clomiphene citrate? In this cycle, in this study, actually, they added 300 IU rather than 150. So it cannot be a mild stimulation. But in the conventional stimulation, when they added clomiphene citrate 100 milligram from day 3 to day 7, they found out that there was an improved stimulation result, but that did not translate to either increased clinical pregnancy and live birth. It just improved the number of oocytes which you can get. What about when you add choreofolitropin alpha in a poor ovarian responder? The study was actually when they combined choreofolitropin alpha with HMG against using only HMG throughout the stimulation cycle. They found out there was no help by adding choreofolitropin alpha. You can just give HMG and probably will get the same result. There was another protocol which was advocated, and that's a flexible progestin primed ovarian stimulation protocol, where they actually studied the protocol when they compared it with an antagonist protocol. In this study, 27 women underwent the FPPOS protocol and 54 underwent the ANTAG protocol. All had poor ovarian reserve, and they all underwent oocyte cryopreservation. In this study, they used 300 units of FSH, which was started on day 2 to day 3. They added ANTAG or medroxyprogesterone acetate 10 milligram per day when the leading follicle reached 14 mm or the estradiol level was more than 200. And when they did, they found out that the median duration of stimulation, the day of commencing pituitary suppression, and the duration of suppression was quite similar in both the groups. The median number of cumulus oophorus complexes, the metaphase 2 oocytes, the total number of oocytes cryopreserved, and the maturation rates were quite similar to both the progestin primed group and the ANTAG group. So you can go for a cheaper protocol like this for a person who's got a poor reserve without compromising the number of oocytes retrieved, and it's quite a viable alternative to the ANTAG protocol. And what about the luteal phase stimulation? Gonadotropins actually cannot compensate for the absence of follicles in an aging ovary, and that's why a stimulation on poor responders may benefit from the exploitation of the multiple follicular waves which happens in a single ovarian cycle. And that's why if you go for a double stimulation where you stimulate both in the follicular phase and the luteal phase, you may get much increased number of oocytes. And there was one study where they did follicular phase stimulation and luteal phase stimulation. That is, a dual stimulation was actually compared with a follicular phase stimulation alone, and they used the same protocol, that is an ANTAG protocol. An agonist trigger was given, ICSI was done. They did a PGD for aneuploidies, and they did a euploid single blastocyst transfer. 100 patients underwent only follicular phase stimulation, and 91 completed the dual stimulation. The results were, when they used both, that the luteal phase stimulation was added on, most oocytes were obtained, and they had a similar developmental and chromosomal competence as paired to a follicular phase stimulation, and the results were quite astonishing. 7% for follicular phase stimulation, and it was 15% when they used a dual stimulation. And what about the comparison between the long agonist protocol against antagonist protocol in different ages, like the Poseidon group 3 and Poseidon group 4? When they did it in 1,233 patients with a poor reserve, and all of them underwent the same stimulation protocol, and a fresh transfer was done on day 3. The GnRH agonist protocol was correlated with a higher implantation rate than the ANTAG protocol in the group 3 patients. Actually, in the group 4 patients, there was no difference between the agonist and the antagonist protocol, but there was a strikingly increasing results in agonist protocol for group 3, and that they correlated to the embryo quality or the increased better endometrial receptivity in younger patients of group 3. So what about adding HCG in the follicular phase, which was the other methodology which is done by many studies? Here they added 100 units of HCG to short GnRH agonist protocol from the onset of the follicular phase. That is, they started in the early follicular phase also, but it did not improve the number of top quality embryos and clinical pregnancy rate. There was one study from China where they had added HCG only in the early follicular phase, and they compared it to another group where they added it in the late follicular phase. And they say, when you give HCG in the early follicular phase, it seemed to give much better results compared to adding it in the late follicular phase. And this is the short agonist protocol, which is being advocated for many poor responders, and it seems to work. And the other protocol which has been advocated is a mini dose agonist protocol. That is, you do not give 500 micrograms of tryptolin. You give 100 mics of tryptolin from the mid-luteal phase until menstruation, and then reduce it to 50 micrograms per day. But in this cycle, you will need to give progestogen in the previous cycle to reduce the cyst formation which can happen in long protocols. It's quite useful for poor responders. What about the antagonist protocol, which has been advocated for almost a decade now for poor responders? The pregnancy rates are quite similar to the short agonist protocol, and the two meta-analyses found out that there's no difference between an antag and a short agonist protocol. Short agonist protocol seems to work much better. And natural cycle IVF, it's got a cancellation rate of almost as high as 50%, so maybe it's not advocated. Regarding the modified natural cycle IVF, suppose you've used a high dose FSH protocol in the previous cycle, and the patient has come out with a hypo response, probably you can go for a modified natural cycle IVF because it shows the results of 8 to 18% per patient when you go for a modified natural cycle. Addition of growth hormone, which has been done by many centers, they have said there's no evidence to demonstrate an increased chance for live birth for a person who receives a growth hormone for poor response. And they gave 12 units from the day of ovarian stimulation, and they compared it with the placebo, and the results were quite similar. And this is how they added growth hormone, and this was done in a short agonist protocol. And regarding the pre-treatment, before you go for your stimulation, suppose you add oral contraceptive pills in the previous cycle, progesterone or ethinyl estradiol. These are all strategies to improve the follicular synchronization, prevent a premature ovulation, and to schedule your cycles. There was no difference noted in the pregnancy rate, but when you give OC pills in the previous cycle, it's going to increase the duration of stimulation. It's going to make it much more expensive. Regarding the adjuvant therapy of dihydroepiandrosterone and transdermal testosterone, these are believed to improve the intrafollicular environment and the follicular sensitivity to the exogenous FSH you're going to give. Available evidence shows a very modest improvement in the various parameters, which include the number of oocytes, embryo quality, and live birth rates. And there's no point in adding low dose aspirin as an adjuvant therapy. It does not have any use in a poor responder. Regarding testosterone, it enhances the FSH induced granulosa cell gene expression. It will exert a paracrine effect in the early follicular phase. And when you give, the dose is actually a gel, which is 12.5 milligram applied daily for 21 days preceding the cycle. The other drug which is being used is dihydroepiandrosterone. It augments the effect of gonadotropin stimulation via a paracrine effect, and it is mediated by the insulin-like growth factor. The dose is 80 milligram per day for 2 to 3 months before stimulation. And then there's another technique to improve the response, that is a luteal phase manipulations. This you do to suppress the FSH secretion in the luteal phase so that you have the increased number of oocytes coming after you retrieve. And in poor responders, they say when they usually have an early exposure to FSH, which can cause follicular size discrepancies also. And when there is a discrepancy in the size, it can encumber the coordinated follicular growth, and it will reduce the number of follicles which reach maturation. And the techniques which have been advocated is the use of estradiol in the luteal phase of the previous cycle, using GnRH antagonists in the previous cycle, or you combine both drugs to manipulate the luteal phase so that you get enough suppression and you get a good oocyte number which is synchronized in the cycle you want. And 17 beta estradiol, the dose is 4 milligram per day from cycle day 20 until cycle day 2. And they did a conventional stimulation antag protocol, and they found out the size discrepancies were attenuated in the treatment arm, and there was a significantly low cancellation rate. And the other method is you give an antag 3 milligram in the previous cycle on day 25. And day 2, there was a reduced size disparity and there was a reduced follicular diameters. And probably the prevention of luteal phase FSH helped in the early prevention of early follicular development, and the follicular development happened during the stimulation cycle. And you can combine both, but there's no added benefit compared to a single drug therapy. And another study compared in the usage of letrozole with antag in the previous cycle, in the luteal phase of the previous cycle. And they also compared the usage of estradiol with the antag, and both showed similar outcomes. That is, if you use letrozole or estradiol and you combine it with an antag, they all have equal results. Using a single drug also seems to give the same results. There's something where they did everything. All the masala was added. That's called the AACP protocol, where they gave OC pills and agonist in a long stimulation. And on cycle day 2, they gave antag instead of agonist, 0.125 milligram, half the dose. And they added 2 milligram estradiol valerate as 2 doses 3 days apart. And then estrogen suppositories were given until dominant follicles formed with the conventional stimulation. The stimulation is almost with 600 milligrams of FSH or HMG, and they brought out a pregnancy rate of 25 to 27%. The study came in 2008, and I don't know how much it's feasible to do all this. And the other method is using oocyte accumulation and embryo banking. You stimulate, collect all the mature oocytes, retrieve them and keep it, vitrify them. Then you inseminate simultaneously, and they say the embryo transfer cancellation rate was much lower. So the key points for this talk will be, please individualize a protocol for any person who's a hypo responder or a poor responder. Avoid high dose gonadotropins beyond 300 international units. It may not help. In groups 1 and 2, that is the person who's having an unexpected response, probably giving an optimal dose of gonadotropins even at the start may help her. And you can add REC LH or HMG if she's having an unexpected poor response. In groups 3 and 4, these are the methods which have been advocated recently. The one which has been said again and again in so many studies and in guidelines is the minimal stimulation. That is using only 150 IU of gonadotropins for your stimulation. That's been actually ASRM guidelines are for that. Addition of clomiphene probably in some patients. Go for a flexible progesterone primate ovarian stimulation, which also gives a good result. Double stimulation definitely helps. GnRH agonist protocol is much better for a group 3 patient, that is a young patient with a good, the poor reserve. A mini dose GnRH agonist protocol is also very good because you don't use much of gonadotropins here also. Modified natural cycle will help. Luteal phase manipulations can be tried, and oocyte accumulation and embryobranchi will definitely help the patient. The ones which are doubtful value is the addition of corifoliatropin alpha, antagonist protocols, the addition of low dose HCG to your stimulation protocols, going for a natural cycle IVF, addition of growth hormone, or any pre-treatment technique may not help the patient who's having a poor response. Thank you so much for a patient hearing. Thank you.
Sharmila, that was a great talk. You had gone through literature very exhaustively. For the sake of people who are listening out there, I just would like to simplify it a little bit more. Just yes, simplify it a little bit more and make it more straightforward. There are some strategies which are a proven benefit today, okay, in proven benefit in the overall outcome. Number one is the dosage. There's absolutely no point in increasing the dosage of gonadotropins to anything over 300 under any kind of a situation. And I think all of us, and including our students and fellows, should get used to using the Poseidon criteria, because under the Poseidon criteria, the 4 categories that they have are totally different from each other. And some, it's like comparing apples and oranges. Some have the follicles in them, some do not have the follicles in them. And if you don't have the follicles in your ovary, that doesn't matter what you do, you're not going to get anything. Okay, but there are people who are sitting with follicles in there. The strategy that you use in them is slightly different from the strategy that you prefer to use in people who are starting with no follicles. And one thing that we usually tend to teach our fellows is follicular oocyte ratios. You know, when you've got so many follicles in a cycle, when you're starting out with, how many oocytes are you getting in there? And follicular embryo ratio. So if you start calculating it for every one of your patients, then you know whether you've used the appropriate strategy for that particular patient. Okay. If it's less than 30%, like you start out with 10 follicles, and you're ending up with less than 3 oocytes, then something has gone wrong with the stimulation protocol. Okay. And anything that's close to 70% is very good. So if you've got 10 follicles to start out a cycle, and you've done your stimulation at the end of it, if you're getting 7 oocytes, then you've done a great job. Okay, so the closer to 7 you are, the ideal procedure has been applied to that patient. And otherwise, you have to look at where you went wrong, whether it was okay or not. Another little thing that one can start doing it is also the cohort of the follicles that you're starting with, number of follicles that you're starting with, and the cohort of the follicles that you're starting with. The cohort again has to be a uniform cohort. And if you're starting out with a cohort that is not uniform, then your outcome in terms of follicular oocyte ratio is going to be poor naturally. Some will take off, and then you'll end up with only a fraction reaching maturity at the end of the cycle. So I think we should get used to using Poseidon criteria. We should get used to using the follicular oocyte ratios and sort of troubleshooting ourselves to see whether we ended up using the right protocol for that right patient. But overall, you've done a very thorough review of the literature, and thank you very much.
Thank you. Thank you.
Are we ready to move on to the next talk, Priya? I think we've time is also getting less. Maybe we should. Varsha is next, I think. Pranay is third.
Ma'am, Varsha is having some network issues.
Okay,
so
that's fine.
she's
That's
got,
fine. That's
we'll
fine.
go with ahead with Pranay and then
Yeah.
we'll have Varsha. Thank you, ma'am.
Somebody is going to introduce him, or do you want me to do that? He's from Maulana Azad Medical College in Delhi. Got a diploma in reproductive medicine from University of Kiel, Germany. X-ray certified clinical embryologist and Hall of Fame embryologist from ET Health World Fertility Awards. And science in art, I guess it's a diploma from University of Nottingham, UK. With a distinction, specialist training in reproductive medicine in Singapore, PGD certified embryologist, and an executive member of IFS, an Academy of Clinical Embryologists. And I'm happy to have you with us, Dr. Pranay. And the topic that you've chosen is a very fundamental topic that all of us should be familiar with, and it is the semen analysis. And we're eager to hear you.
Thank you so much, ma'am. I'll just start my screen sharing.
Yes, sir.
So, is this fine? Are you able to see my first slide?
Yes, sir.
Thank you so much. Thank you, IFS Tamil Nadu chapter, for having me here. And it's an overwhelming task to follow the talk that we just had and to be gapped up between the first talk and the third talk. Also, I think if you are to talk about more sophisticated things like micromanipulation or PGD, I think with the expertise, you tend to tide over those things. But once you are asked to revisit things which are simple, something like the semen analysis, it becomes a very overwhelming task. So without further ado, and because of the scarcity of time, let's get into it. We have recently seen a revision of the WHO semen analysis. And we now know that the male factor is solely responsible for causing infertility in about 20 to 30% of the couples. And the male factor is contributing up to 50% of the cases. But apart from performing a semen analysis, this is often overlooked and underdiagnosed area. So it is very desirable that we investigate and correct for any hidden and cryptic defects before we start the treatment, and in order to shorten the time to pregnancy, and so that we're able to have a specific rather than empirical therapy. We also know that normal semen analysis does not guarantee the fertilization potential of the sperm, and that there is significant overlap between the values between fertile and infertile men. And there's a lot of biological variability even in samples taken a few days apart. Also, semen analysis does not provide information regarding sperm function defects. But all that being said, I think it is imperative that we perform semen analysis as a first and foremost test before we go on to ordering an array of a battery of tests for the female partner, so that the male is an equivalent and equal participant in the treatment of infertility. So semen analysis parameters have long suffered from something where it has been remarked that even if the report is not precise, men are not going to die of an inaccurate result. So this is a statement that I have dug out of a review by Lars Bjorndal, one of the contributors of the WHO Semen Analysis 2020. And the review also makes a statement that an imprecise semen analysis might be accurate enough for medically assisted reproduction, wherein we have to just see whether we have to fast track the patient to timed intercourse, or are they to be offered IUI, or is the patient directly for IVF-XC. But laboratories worldwide need to achieve improved diagnostic compliance, particularly if they are to publish and collate data or they are performing clinical trials. So the available methods that we have as of today for conducting semen analysis are the routinely performed manual microscopic method, computer-aided semen analysis or the CASA, and the recent onset of sperm quality analyzers. As I've said, there's no gold standard with regards to the investigation for infertile men. But as far as what we have today, the WHO guidelines are widely accepted as a standard across the world. So in the new revision, the WHO Laboratory Manual for Examination and Processing of Human Semen, this is aiming at facilitating precise compliance with the recommended procedures. It is giving step-by-step instructions that are easier to follow than the previous edition. There are fewer variants in dilutions and calculations. And there's a concurrent publication of a formal ISO standard based on same evidence, which facilitates accreditation according to the WHO principles in this field of laboratory medicine. This updated step-by-step manual is designed to reduce inaccuracy and imprecision in measurements, so that the resulting semen parameters are comparable amongst individual technicians and across laboratories worldwide. One of the important deviations is that this version of the manual, WHO manual, has done away with the reference value as and it is more focused on giving diagnostic values. So before the 2020 version, we have seen 5 iterations of the WHO manual, the first being in 1980 and the last being the WHO 2010 fifth manual. And this was done using collating data from a lot of Caucasian countries, but it did suffer from some drawbacks which were heard upon and drafted into the 6th edition. And let's see whether the 6th edition does the justice to the grievances which were raised in the 5th edition or not. So up until 2020, we were using the 5th edition, which was the most extensive and comprehensive edition. It derived its data from a population of 1,800 fertile men, which were able to father or have pregnancies with partners who had an abstinence with an abstinence period of 2 to 7 days, and the time to pregnancy was up till 12 months. So the 5th centiles in this manual were presented as lower reference values. It also included the total sperm per ejaculate, which was an important parameter, which went on to say that even if you have a volume which is lower than the threshold, but you which account which is lower than the threshold, but you have adequate volume, a total sperm per ejaculate would suffice. It also had methods to estimate very low sperm counts and errors when reporting no sperm in ejaculate. And there was focus on the sperm preparation procedures from testicular and epididymal sperm. Also focused on cryopreservation of semen sample and update. There were references to updated methods of quality control and assurance. However, there were some limitations to the 5th edition, and the foremost was that some of the subjects, particularly for the reference values of the vitality and semen volume, were very less. We can see that there were only 428 candidates for the vitality assessment and the 1941 for the semen volume. And since it was coming from underrepresented population, mainly the Caucasian population, there was no data, for example, from African or China, so which constitutes a bulk of load of IVF cycles being carried out worldwide. Also, there was a lot of heterogeneity regarding the sperm counting chambers that were used to assess concentration, and there was no clear information regarding the number of samples to be assessed using each chamber. So when we see the major differences between the 5th edition and the 6th edition, we can see that as compared to the 5th edition, now the 6th edition is not treating male just as a semen sample. It is treating the male, assessing the male and diagnosing the male in totality. So the focus has shifted from solely focusing on having a semen analysis so as to guide the medically assisted reproduction procedures, to having infertility diagnosis and assess the male reproductive health as well. So the concept is that patients with diminished semen parameters in terms of count, motility, and morphology will be harboring other chronic defects as well. And it is important to treat the male as a whole rather than treating a specific defect. It is also guiding the choice of ARD procedure as it was before, but now we can also monitor response to treatment, measure the efficacy of male contraception, and eliminate previously outdated tests that were very cumbersome to perform. We are carrying out from the data that was drawn for the publishing of the fifth manual, and this has been collated with the data that has been derived in the previous decade. So if we look at the differences between the fifth and the sixth edition in terms of the microscopic parameters, the differences are very subtle, and I'm pretty sure that some of the labs have not even shifted from the fifth to the sixth version for the semen analysis reporting, because you can see that the 0.1 ml difference in this volume, 1 million per ml difference in the count, and so on and so forth. So the differences are not very drastic. But what has happened is that the manual is a lot more comprehensive in terms of performing the steps in an objective manner and doing away with redundant things. So, for example, we have a lot more representation from countries like Africa, Oceania, Americas, and we have been able to have these many studies coming in after the WHO 2010, wherein we have representation not only from Caucasian countries. So after its publication, the fifth edition was heavily criticized for suggesting reference ranges of semen parameters as a mainstay in the evaluation of male fertility potential. And the concerns regarding the 2010 references surrounded its possible inadequacy to represent general population due to the voluntary nature for the inclusion for most of the cohorts. So if we are to see the sixth edition, essentially the new manual comprises 3 parts: semen examination, sperm preparation and cryopreservation, and quality control and assurance. So the procedures for semen examination include basic examination, extended examination, which may be used for laboratories or clinicians in certain situations, and advanced tests, which are routinely not recommended, but can be used for research purpose. So as I've already mentioned that the sixth edition is not only looking at the male partner as a semen sample itself, but looking at the male partner in totality. The semen examination, the most commonly performed examination is the basic semen examination, which is a routine wherein we have the microscopic and the macroscopic parameters, and the extended examination, which can be ordered by the laboratory or the clinicians in certain situations, like the sperm DNA fragmentation. So the basic examination is now focused on sperm number, motility, morphology, and only if the motility is poor, only then we are ordering vitality. So the sperm concentration is being done by the use of hemocytometer, which is being recommended. There's a lot of emphasis on doing away with the other commercially available chambers like the Mappler chambers and the others, which have a improper depth of 10 microliter as compared to the 100 micron depth, which has to be followed. And then we are also reporting motility, and there's a return to the previous 4 categories, wherein we are A, B, C, and D. And this was done away with in the 2010 manual, the 5th edition, wherein we had rapid, slow, and non-progressive, rapidly progressive, non-progressive, and immotile sperms. The vitality testing is now being recommended as being to be done only if the motility is less than 40%, and the recommended test for diagnostic use is the nigrosin test. So when we look at the macroscopic parameters, we are talking about appearance, odor, liquefaction, viscosity, volume, and pH. And in the microscopic examination, the parameters that are mentioned, the motility, concentration, morphology, and the vitality. Before performing the semen analysis, some instructions to the patient, which have been re-emphasized in the manual, are to avoid the use of contraceptive methods, the barrier contraceptives or coitus interrupters, because the volume of the semen will be grossly underreported. Adequate instructions to be given to collect the entire ejaculate. Emphasis to be done given to the labeling and date and time of collection, and that the semen analysis be carried out within an hour of collection. So it is now recognized that the semen sample, if not liquefied adequately, will contain islands of heterogeneous sperms. There will be some islands which will have more concentration of the sperms, and to have a precise homogeneous representation, you need to have adequate liquefaction. So you can aid that by either letting the sample sit for 30 to 60 minutes, or you can achieve that by swirling the sample around. Then the period of abstinence is the same, 2 to 7 days. 3 days is optimal. And after the 7 days of abstinence, you'll have more immotile sperms coming in. The count will certainly increase, but the motility will decrease. The appearance of the ejaculate will also give an indication to a lot of hidden conditions, like pyospermia will have a yellowish semen. A grossly yellow semen will be indicative of either the patient having jaundice or taking vitamin supplements, and so on and so forth. And similarly, a grossly malodorous semen sample will be indicator of either a urine being a major part of the constituent of the sample, or putrefaction being there in presence of microbial contamination. So for the sake of the time, I will skip through some of this. But again, 1.4 to 6 ml of ejaculate is considered normal. You'll have lesser volume due to shorter abstinence or retrograde ejaculation or ejaculatory duct obstruction. The volume does increase by 0.5 ml per day until the 5th day of abstinence. However, longer period of abstinence do not improve the quality of semen, and in fact, they are detrimental for the semen quality. Viscosity is again being reported subjectively as the length of the strands which fall through the pipette after a period of 60 minutes wherein the semen has not liquefied. Semen pH is to be reported because the semen pH is indicator of subtle microbial contamination being present, and an entire completely acinozoospermic sample might be there because of presence of spermatozoa being immobilized at a pH of less than 6.2, and this is commonly due to infection of seminal vesicles or prostatic infection. Coming to the basic semen analysis, you are looking at the concentration of the sperm using hemocytometer. Although appearing well mixed macroscopically, we know that there are some small compartments with varying contents of spermatozoa. So it is recommended that you work with 50 microliter of semen sample with a positive displacement pipette and use a hemocytometer of 100 millimeter of depth rather than microchamber or the likes. Perhaps the most significant change in the 6th edition is regarding the reintroduction of the distinction of rapid progression from slow progression. And now we are back to the previous 4 categories of A, B, C, and D based on the velocity of the sperm. So when we talk about a sperm being rapidly progressive, grossly it is crossing 5 head lengths per second. So if you look at it in a chamber, you'll see that one block will be traversed in like 4 seconds. So put simply, a rapidly progressive spermatozoa is one that moves more than 5 head lengths per second. And for motility assessments, you are taking a 10 microliter aliquot under a cover slip, which is the most practical. And now the manual is also recommending that since the velocity is highly dependent on the temperature, you have to standardize the temperature of the stage on which the motility assessment is also taking place. So you have to keep the stage temperature at 37 degrees. Again, sperm morphology, nothing different from the previous version. The lowest reference range of morphology is 4%. But now we have a lot more better quality micrographs of spermatozoa, wherein we can actually go and see what is close to a normal looking sperm. So previously we had the head, midpiece, and tail and cytoplasmic residue, and we know that the head should have 40 to 70% of the acrosome occupying the area. The shape should not be pyriform. There should be no large vacuoles in the post-acrosomal area. Up to 1 to 2 small vacuoles in the acrosomal area are permissible, and so on and so forth. So nothing much has been revised as compared to the previous version, but now we have a lot more reference pictures. Regarding the indications for vitality assessment, the 6th edition has addressed an inconsistency which surrounded the assessment of sperm vitality that existed in the previous edition, wherein if progressive motility was below 40%, vitality testing was recommended, but 40% itself was a threshold that corresponded to the total motility. So in now the sixth edition of the manual, we assess vitality when the total sperm motility is below 40% and not the RP fraction. Obsolete tests such as human oocyte and human zona pellucida binding, which are very difficult to perform out of experimental settings, and the hamster oocyte penetration tests have been removed. Research tests in this edition include assessment of ROS and oxidative stress, membrane ion channels, acrosome reaction, and sperm chromatin. And CASA has been rewritten to describe the principle. CASA analysis has been incorporated, and its use as research technology has been emphasized. In addition, emerging new methods using sperm movement or changes in light, in which the light may constitute the basis of measuring sperm motility, has been touched upon. So now we are talking about the advanced methods wherein the oxidative stress and sperm DNA damage have been laid emphasis upon in the latest manual. There are sections which talk about sperm preparation and cryopreservation in detail, and the section 3 of the manual lays emphasis on the quality control so that you can perform statistical analysis by using easier approaches, even if you're not adept to using statistical tools or methods. So the 6th edition has presented the basic examination in a step-by-step and temporal manner so that it can be reproduced precisely in any laboratory with the required equipment and expertise. The sections on extended and advanced examinations have been completely revamped in concordance with the current clinical practice, with many older tests being abandoned and newer tests like sperm DNA fragmentation and ROS testing being adopted. Data that was not previously reported and from more diverse population has been incorporated, and these analyses have validated the distribution of results defined in the previous manual. There's a so that we are able to have a meaningful exchange of ideas and draw in data from multiple centers, either for publications or multicentric or RCTs. There's a need for standardization, and for this global standardization, there's a lot of emphasis being placed in the current manual. We've talked about the change in motility and how it correlates and is a welcome improvement, because amongst all the parameters, the single most parameter which is predictive of live birth rate is the motility. So we are welcoming this change of ABCD being reintroduced. Amongst the various methods of sperm DNA fragmentation testing, there's one comment on comet assay being a little imprecise, and so that its routine use in clinical practice is not recommended. The editors have not mentioned specific thresholds for the SDF testing, and it is up to the laboratory to set their own reference ranges. Similarly, the manual sees a lot of relevance for ROS testing, and even again, just like SDF testing, ROS testing thresholds and methodology has not been recommended, but the manual does mention that it sees a wider uptake of these two extended examinations being conducted. These are the two tests that have been discarded: the sperm cervical penetration test and the hamster egg penetration test. And recently, I could dig out a SWOT analysis of the 2020 semen analysis by the WHO 6th manual. And we have basically covered a lot of this. The strength of the manual is that it gives insights in the global management of male infertility, and it addresses the previous criticism of the over and underrepresentation of the Caucasian population and the other populations. Also, the newer tests like the SDF and extended tests have been introduced and emphasized upon. But there are some weaknesses. I mean, apart from this representation from the China and the Oceania, there are some geographical areas that are still underrepresented, and we still have a lot of lack in the data regarding the thresholds that are to be set for the extended testing. And the newer manual is I think we have to take this with a pinch of salt, because these authors, they come from the Cleveland Clinic, where they're doing a lot of work on oxidative stress and things like sperm DNA fragmentation and meiosis and all. So to say that seminal oxidative stress tests are considered as specialized and research-based is not an overstatement. I think for us to use them in routine laboratory, we still need a platform which can do this without adding to a workload. So I would beg to differ with this. But of course, this gives us a lot of opportunities to collate data from various centers so that we can come together and collaborate and publish a lot more. The threats are again, and something that I agree with, that the abundance of technical details in the manual will diminish interest among the clinicians, and with it, especially somebody who's looking at only the change in microscopic parameters in terms of count, motility, vitality, wherein not much is different from the fifth edition of the manual as compared to the current manual. But again, the lack of reference values for basic and extended semen parameters is something that can be worked upon in the forthcoming manuals. So with that, in summary, we can safely say that now the manual is laying emphasis on male fertility and male health in totality, and looking at the male as an individual rather than just a test. It is facilitating step-by-step examination and laying emphasis on evidence-based techniques. We have a lot more representation from previously underrepresented populations. This manual is supported by a new formal ISO standard. We have introduction of decision limits rather than previously variable reference ranges. And in the form of extended testing, the sperm DNA fragmentation and oxidative stress testing have been emphasized, which would be the forerunners for the decade to come as far as the extended analysis is concerned. Thank you.
Thank you very much for that very elaborate discussion. And I think it was very good that you went about the sixth manuals step by step. And I think this has been a particular peeve for a lot of us who've been in this scenario of ART for a long period of time, the quality of andrology testing outside of ART laboratories, okay? And I'm sure, most normal laboratories which are doing everything and also doing a semen analysis have no idea what is the current thing that is happening. And I think that we can make out from, for an ART unit, somebody else comes in and says, this is my testing done in an ordinary laboratory that does everything else besides semen analysis. And it talks about a 95% of sperms being normal and no description of morphology. You immediately know that you can just check it off and take another one there, kind of a thing. So the first thing I tell them is look at the morphology and say what they're stating. And if you don't have a morphology, and if you have an inadequate morphology, that sperm test is actually doesn't carry much value at all, okay? And there is usually no time of collection and no time of checking either. So I think the need of the hour for all of India, if you ask me, is good andrology laboratories. Okay? Inside of the ART laboratories or outside of ART laboratories doesn't make any difference. But I think, somebody who does a standardized testing on a semen analysis, including the timing and where it should be checked and how it should be checked and who it should be checked by. And you may not even have a newborn chamber, which is the appropriate newborn chamber, which has only come now. For years together, it's been not newborn either, okay? So I think those kind of things are extremely important in what the society needs. And I'm happy you talked about the DNA fragmentation as well in the sperm test as being the next thing, and also ROS testing. And just happen to know a few of the things that are happening in that scenario. For ROS testing, I think pretty soon you will see something in the market that you and I can use, okay, safely, securely. And it's almost like a card test where you can put in a drop and it'll indicate low, average, or it doesn't give you a quantification, but it gives you an indication that the levels are inappropriate, kind of a thing. And in which case, then you can go for further testing of DFI, or putting them on antioxidants becomes much more sensible treatment as well if you do that. So that is on the anvil, and probably very soon, I think it will be in the market. That's what I hear from outside. And DFI, we have a lot of information because we've been doing DFI as part of our extended testing for many, many years now. And we are getting samples from almost all of India. And the chromatin, SESA is the testing that we have been using. And SESA, we have such a large number of samples from all over India. And what we are seeing is very, very, very interesting. Okay, in that age over 37 in men, we are finding consistently high DFIs, Indian samples. Okay, so there is an age-related change. We've been talking about age-related changes in the oocyte for a long period of time. But there is actually, this has been published in North American Journal of Research as well. This is our numbers, but it's been published. But there's no doubt that the DFI goes up beyond the age of 37. So you've got another parameter that you're dealing with. If you've got a failed implantation, failed even blastulation in some of your embryos, it may be the male factor rather than the female factor, a male factor, which is not staring in your face, which would be aware if you were doing it as an extended test. So that is one indication. Second one is actually the profession. And I've asked a lot of people this question: what do you think is the profession? Okay, where the DFI is higher in Indian men. And surprisingly, the answer is agriculture. It is agriculture. It is not desk jobs. It is not a lot of other things that people think of. And it is actually agriculture. And I think it's got a lot to do with the way our farmers are handling pesticides and chemicals, and not even pesticides, even fertilizers are not good for male gamete. You know, and if they handle it by their hands and use a lot of it, I think that category has the highest DFI in them. And it might reflect in what we do in the ART laboratory. Okay, ultimately getting a good embryo, getting a good implantation may not even be the female factor, and it may be the male factor. It would be nice to have Varsha as well to talk about the oocyte factors, because both of us have done some articles together, me and Varsha. Is Varsha still there, and has she gone?
Yes, ma'am, she's come.
Okay. Varsha's slides are there? Are you okay?
Yes, ma'am, she's already tested her slides.
Okay, that'll be good. Okay, we'll go ahead with it. Varsha is somebody that I've known for ages, and I think she is one of the leading embryologists in India as far as I'm concerned. She's past president of the Academy of Clinical Embryologists India, and recipients of many, many awards, and from Manipal hospitals. Head of embryology team that succeeded in the birth of India's first IVM baby. Yeah, she was working with IVM for a lot more than a lot of other people do. And Karnataka's first vitrification. Was that so? Okay, that's good. Academics, she's a reviewer. She's on the editorial board of very important journals, clinical coordinator for research and embryo viability. And she's got so many articles which are published as well. I'm waiting to hear from you, Varsha.
Varsha, do you want to share your slides? Yes. Super. Varsha, you're muted.
Sorry, can you hear me?
Yes, Varsha.
Yes. So thank you so much, ma'am, for the kind introduction. And it's such an honor to do a presentation with ma'am as the chairperson, because we all know ma'am over so many years, and she's not only been a teacher, but also an examiner at the at all the different high-profile exams that are conducted in India. So it adds a little more of stress, especially on me when I have to present it in madam's presence. I would like to thank IFS for giving me this opportunity. Thank you, Dr. Priya and Dr. Rajapriya for having me here. So this is a very interesting topic, oocyte quality and polycystic ovaries. And we always kind of keep debating, other oocytes, compromised, are they not? And when we have these kind of discussions with embryologists, many of us have different opinions. So the question is, are they affected? Are they poor? Are they better? Or are they just, is the oocyte quality very similar to the non-PCOS patients? As we know, PCOS is a heterogeneous collection of signs and symptoms. There are many extra-ovarian and intra-ovarian factors which are attributed towards the pathophysiology of PCOS. But what remains central to this disease process is that the ovarian dysfunction. The syndrome is surrounded by controversies regarding not only the diagnosis and the treatment, but also if the oocyte is impacted, and if so, to what extent. So PCOS is a generic description for broad spectrum of clinical morphological findings in women which are associated with endocrine and metabolic disorders, signs and symptoms of androgen excess and ovarian dysfunction. PCOS encompasses a woman's life cycle, starting from in utero, and in the figure, the factors that potentially impact the pathophysiology are shown in circles. What is important is that to understand that not all of these factors would be affecting each individual. PCOS is a biologic network of interactions between neuroendocrine, hormonal, metabolic, genetic, and environmental influences. So you have one spectrum of PCOS where the patient just has an ultrasound finding of a polycystic ovary, which is called as polycystic ovarian morphology. And the other spectrum, you have a full-blown PCOS where, along with the ultrasound factors, there are also abnormal biochemical factors and also signs of androgen excess. So PCOS forms the main cause of infertility in our OPDs today, approximately affecting around 18 to 25% of the patients. We are aware that the GnRH pulses from the hypothalamus act on the anterior pituitary to then influence the release of FSH and LH, which then regulate the production of follicles and also the gonadal steroids in the ovaries. The FSH acts on the granulosa cells, causing release of estrogen, whereas the LH acts on the thecal cells with the release of androgen. These androgens produced by the LH-stimulated theca cells are the main substrates for FSH-induced estrogen synthesis. Now, when this entire loop, this forms a feedback loop, which then regulates the entire process. So when the hypothalamic pituitary ovarian axis undergoes dysfunction, then we see a condition called as polycystic ovarian syndrome, where the GnRH production abnormalities are seen, basically a hyperactivity of these, causing to an alteration of the FSH-LH ratio with increased LH releases, and this in turn causes an increase in the androgen production. So when we talk about PCOS, apart from these extra ovarian factors which influence, there are also intra-ovarian factors which can influence, like growth factors, cytokines, increase oxidative stress within the follicles, and all these can impact the oocyte quality and hence causing an impairment in the embryo quality as well. So this leads us to a state where there is premature growth arrest of the antral follicles, which is very typical of PCOS. There is also altered oocyte maturation as far as the oocytes are concerned. So if we look at the PCOS ovary anatomy macroscopically, there is increase in the volume of the ovary. These are enlarged ovaries, which we see on the scan, a typical picture of a thick capsule, increased medullary stroma, and a lot of these peripheral cysts or follicles sitting in the periphery. Microscopically, again, there is this range of subcapsular follicles that are seen, which are at various stages of atresia, a thick stroma, and hyperplasia of these thecal stromal cells. And all this is related to the excess release of androgens and hyperinsulinemia. Now, when we talk about oocyte quality, we are aware that there is a very close and an intimate interaction between the oocyte, the cumulus, and the follicular fluid. This is extremely important and critical for the oocyte health. The granulosa cells facilitate oocyte maturation. The oocyte in turn helps development and differentiation of the granulosa cells. But in this whole process, what is important are the gap junctions, which allow a bidirectional exchange, or it allows the signaling of molecular messages between the cumulus cells and the oocyte. And this is extremely crucial for adequate or healthy oocyte development. So what are the different factors that could be affecting oocyte quality? There are these intrafollicular changes which occur during follicular genesis, the incomplete oocyte maturation or abnormalities of oocyte maturation. All these are related to an excess of an androgen milieu in which the oocyte is growing, excess of insulin, and to add to this, obesity kind of messes up with the whole thing and adds to the entire problem. And this becomes a vicious cycle. So when we talk about oocyte quality, most of us understand it as just the morphological aspect. Does the oocyte morphologically look normal or abnormal? If it is dysmorphic, what are the different abnormalities in the oocyte that you see? But I think today is the time, now are the times when you need to think about oocyte quality in the bigger realm. So oocyte quality represents the developmental competence of the oocyte, and it's not related to morphology alone. It is the ability of the oocyte to undergo maturation, fertilization, embryonic development, leading to a successful pregnancy. So when we talk about oocyte quality in context of PCOS, we are not only going to look at the morphological aspect, we are also going to look at the genetic and the omics, which is the metabolic profile, the proteomic profile, and the genomics of the oocyte. So quantity versus quality, we all are aware that this is a stage where usually you expect higher yield of oocytes. If you look at studies, there are various reports which contradict each other. Some say that in spite of the high numbers, they perform similar to those patients who are not hyper-responders. Some studies suggesting that these high numbers can actually lead to a reduction in the oocyte quality and hence an inferior embryo potential of these embryos. Regarding the fertilization and cleavage of PCOS oocytes, again, you have conflicting evidence there suggesting that they could perform as normal as non-PCOS patients. Some studies suggesting that PCOS oocytes show a higher degeneration rate, a reduced fertilization rate. You get a higher number of immature oocytes in case of PCOS, but there are reports also suggesting that they perform as similar to non-PCOS. Studies also suggesting that PCOS embryos lead to a lower fertilization and implantation rate, majorly seen in patients with insulin resistance. So there is also a suggestion that when PCOS patients go through controlled ovarian stimulation, then to some extent it allows the correction of this abnormal endocrinological milieu that the oocytes are growing in. To some extent, it may cause normalization of the LH. However, this may not be possible in those high BMI, obese, insulin-resistant women. So to some extent, COH may allow for correction of abnormal LH. Now, the question is, why do we see such conflicting outcomes as far as the oocyte and performance of oocytes in polycystic ovaries is concerned? And we need to give this a thought. That we are aware there are different phenotypes of PCOS, and I'm not going into the details of the different phenotypes based on biochemical parameters, the menstrual irregularities, presence or absence of ovulatory disorders, and the ultrasound findings. So, for example, if you look at the D phenotype, patients who are categorized into the D phenotype will not have a hyperandrogenic milieu, but they will have irregular ovulation and polycystic ovaries on ultrasound. So when these studies are conducted, and when we read about studies correlating the oocyte quality, they are just categorized as PCOS women. They are not differentiated into different phenotypes, because now we do understand if it is a hyperandrogenic milieu, it can definitely alter the oocyte metabolism. So when we look at markers of oocyte competence, it is not only oocyte maturation. There are different markers, the cellular markers of oocyte competence, which basically tell us about the gene expression in cumulus cells. And this has been studied elaborately. Genes involved in the signaling of the homeostasis, the telomerase activity in the cumulus cells. Also, there are follicular fluid markers. The follicular fluid has extensively been studied regarding the metabolic aspects of the oocyte, the percentage of amino acids, the oxygen consumption, which is an indirect correlation to the functioning of the oocyte. So studies suggesting looking into the gene expression in cumulus cells suggest that the gene expression in cumulus cells is significantly different in PCOS patients. And this is significant because this is related to also the expression of the growth factors. There is deranged mRNA transcripts, and these are involved in the steroid metabolism. And hence, this could to some extent explain the abnormal steroidogenesis observed in polycystic ovarian women. Regarding the follicular fluid and the metabolic changes in metabolic changes in PCOS patients. So when follicular fluid was studied, it did show a significant altered pyruvate mechanism, reduction in pyruvate and lactate, and increase in insulin, which leads to reduced glucose intake. So there is an impaired glucose metabolism that has been seen in oocytes of PCOS patients. And why is this important? Because we know that processes like fertilization and cleavage are very glucose uptake dependent processes. And if we are seeing some errors in the metabolism, it can be implied that this definitely can affect the fertilization and cleavage potential of these oocytes. Now, hyperandrogenic atmosphere, is it really harmful to the oocyte quality? And this is a study which was conducted on a mouse model where the follicular dynamics was studied in a hyperandrogenic environment. This study suggested that when oocytes are surrounded by these kind of hyperandrogenic environment, there is a slowing of the growth rate of preantral and antral follicles. The follicular health is compromised, so is their survival, and there is an excess of ROS. But the important conclusion this study gave us is that the prolonged exposure to androgen excess not only leads to aberrant follicular development, more of atresia, but this will even persist even after you remove the oocyte from the excess androgen environment. So this is important, that even a brief period of exposure to an hyperandrogenic environment to the oocyte can alter the competency of the oocyte. Regarding oocyte morphology, now the first study I quote here from Sigala suggests that as far as morphology of the oocyte is concerned, it doesn't show any compromise, or it is similar to the control group. But let us note that this is the group that was studied here was the PCOM, which means only the morphology on scan was altered in this group, and they did not show any signs or symptoms of PCOS. However, the second study by Sahu et al., which compared the PCOS and the PCO only, or the PCOM group, suggested that they had similar characteristics. However, similar characteristics as regard to the oocyte and the embryo quality. However, the miscarriage rate was significantly higher in the PCOS group as compared to the PCO alone group. Now, this brings us to the next question, that if the miscarriage rate is high, do we understand that the oocyte morphology had any role to play in it? Did the oocyte have any role to play in the increased incidence of miscarriage rate in PCOS patients? So a genetic approach is extremely important. And this study, which looked at the chromosomal composition of unfertilized oocytes, but which looked morphologically normal, suggested that there was no increased incidence of aneuploidy, at least in those oocytes which looked morphologically normal. It is known that another study which looked at the embryonic aneuploidy suggested that no doubt you get a higher yield of oocytes and significantly higher absolute number of euploid embryos in PCOS, and this is only because you get a higher oocyte yield. But when compared towards when they were stratified for age and egg number, there is no increase or no difference in the euploid rate. So then the genetic analysis on abortuses of PCOS patients, both in younger and older females, suggested that there was no suggestion, or there was no conclusion suggesting that the aneuploidy rate was higher in the PCOS women. So this brings us to another important aspect, that the higher incidence of miscarriage could not probably be associated with the oocyte quality, but rather with other endometrial disorders associated with PCOS. Coming to the question, okay, if the oocyte quality is compromised, if not on morphology, if it is the metabolic or the functioning or the competence of the oocyte that is compromised, can we improve the oocyte quality? It is too early to suggest, but today you do have drugs like inositol and metformin, which are considered to probably improve the oocyte quality by reducing the oxidative stress and also the insulin sensitizing activity. But we need to wait and watch, because it is too early for us to suggest if these corrective measures or if these different medications can actually impact or alter the oocyte performance in polycystic ovaries. So to conclude, there is a paucity of clinical studies focusing on oocyte quality in different phenotypes of PCOS. They all seem to be combining it under one bracket, and hence it is very difficult to conclude if oocyte quality is really impaired in PCOS. We do understand that there seems to be some amount of compromise, but at the moment, it is difficult to pinpoint where the compromise in oocyte competence is. Diagnosis of PCOS itself is a heterogeneous criteria with various clinical and metabolic phenotypes. And most of the studies are measuring the outcomes only against mature oocytes, which may not be the right way forward. And hence, to conclude on this topic is not only very difficult and controversial, but I think till we have a clear idea or till the confusion regarding the diagnosis, the treatment, classification of PCOS is streamlined, it will be difficult to pinpoint which are the categories under which the oocyte is compromised. Thank you so much for your patient hearing.
Varsha, that was a great summary of what the literature says and what you've come across over a long period of time. And I agree with you that PCOM cannot be considered as a PCOS. It's the whole syndrome that makes a lot of difference rather than just the morphology of ovarian. I think most of gynecology now agrees that just a morphology does not make a woman into a PCOS. It's a metabolic reproductive syndrome, and you have to have the metabolic reproductive abnormalities rather than just an ovary that looks different, or an ovulation that's there giving rise to a larger ovary and multiple follicles. So I think we've got to be now talking about PCOS rather than PCOM as a causative factor, because the metabolic abnormalities exist in PCOS, but they may not exist in PCOM. Just the morphology is there. They may not have the metabolic abnormalities. But, there is much more literature on what you were talking about, which is actually early pregnancy losses or implanted embryos being lost, loss of the pregnancy in the first and even in the second trimester, inclusive of the cervical incompetence, is much more high in the PCOS group, where there's a metabolic problem. And the conclusion today, or at least the indications today, are this kind of a thing. They're not talking about oocytes that much any longer, but the way they're talking about is the inflammatory process, the metabolic changes cause in a woman. In other words, whether it's hyperinsulinemia or whether it's hyperandrogenemia, two of the most prominent metabolic changes, they give rise to a lot of inflammatory changes, totally inflammatory changes in a woman, which gives rise to different kind of cytokines in her system. Abnormal cytokines, inflammatory cytokines become much more prominent. And that's why I think they feel that a lot of these abnormalities, even all through pregnancies, happen because of the change in the cytokines, which are secondary to the metabolic changes. Very, very interesting, because this is what we have seen with COVID in the last few years. The obese ones do differently even if obesity is the only abnormality an individual has, their mortality, morbidity rates were very, very high with COVID. Okay. And the reason being that it was a chronic inflammatory state. So the metabolic changes are probably much more important. And it will be very interesting if you or somebody can do a study on exactly what metabolic changes, whether it's hyperandrogenemia more than or hyperinsulinemia, which kind of abnormality. In India, we have a lot more hyperinsulinemia rather than a hyperandrogenemia. So which group it is, which subgroup it is, and which changes are there. The cohort which is not being uniform and the immature oocytes being more, that's going to happen, with stimulation of somebody with a very high antral follicle count, it's going to happen, But whether the mature ones are normal or not is the question. I think whether they behave normally in the laboratory. And I agree with you that there is not a marked difference that you see in the laboratory, but what it does beyond that, we don't know. And the very important fact that you've added on is that chromosomally also, nobody has shown that they're any different. And thanks very much for that thorough literature check. Okay. My compliments to everybody. Everybody has done a great job. Okay. And I'm happy that I said yes to you. I'm sitting here listening to everybody.
Thank you, ma'am. Thank you so much for accepting and for being here through the session, and also enlightening us with your thoughts and academics as well. Sahiti, are there any questions for the speakers?
There is one question, ma'am.
Okay, can you please share?
I guess one of the doctor has replied to that.
Okay, that's great. If that's done, if there are no more questions, I would like to thank Madam and all the three speakers for accepting my invitation and for delivering this and making the CME so nice and full of academics and just brilliant done. Thank you so much for that. And thank you to Shield and Sahiti and Chitrakala for all the coordination and the logistics. Thank you so much for being here. Thank you so much. Thanks again.